Hank Wernan from Wernan Consulting, and I have two questions related to changing payment mechanisms. Now, what you mentioned, but two areas you didn't mention. One is you made no mention of Medicaid, which is hugely ripe for payment innovation, and the second is patient-centered innovation in payment mechanisms.
Well, first of all, about Medicaid, that's a complex issue, and I don't really have the expertise because the issue with Medicaid is partly that the policies vary by state, and there is still going to be a lot of heterogeneity in how Medicaid is done. For example, the use of capitation is very common, but not everywhere.
But CMS could easily open the door and say, we want to be innovative at the state level,
oh, yeah,
and we want to support that like crazy.
Well, they
the
have.
opportunity is huge.
I think that's absolutely right. And that's why that Center for Innovation is for both Medicare and Medicaid. So they clearly have said that they want to support that. Now, again, I don't know how effective they're going to be. But could you expand on your second question?
Well, the second one is the patient-centered. The patient self-management is one of the keys to controlling healthcare costs. And if all we do is focus on the provider or the insurance company, we may completely miss the mark on what could be the largest opportunity is patient-centered, where the patient is given an incentive to manage their own care, to select quality providers, to be more cost-effective, and so on. I think their whole rethinking of there would be enormously beneficial.
Yeah, I completely agree. And because my comments didn't focus on that doesn't mean that that was ignored in the legislation. So I just have to point out there are pieces of this, for example, with chronic disease management, where it does include self-management. I think you are raising a really good point. It's gotten a lot less attention than changing what providers do. I can tell you, by the way, that NIH has put a lot of money under the stimulus bill into supporting research into these kinds of issues, how you engage the patient. In fact, we put in a grant proposal to look at using behavioral economics techniques to promote behavior change among patients as well as physicians. But absolutely right, engaging the patients effectively is going to be really important.
If I could just comment, Hank, as an answer to your question regarding Medicaid, I think the conventional wisdom is that most providers are dramatically underpaid in the Medicaid system, and to try to get savings from that system using any sort of innovative technique, and in fact most of the states already use some form of a capitation system, is going to be a problem on the acute medical care side. The long-term care side, which is where the big growth is.
Why not, for example, tie malpractice reform to participating in Medicaid? Because a lot of high Medicaid costs are you don't have specialists available to provide regular care. So you say to the specialist, if you participate in Medicaid, we'll let you participate in some malpractice relief, much as a community health center does.
Good point. Other questions?
Hi, Anne Marie Lynch with AdvaMed. In one of your early charts, you compared life expectancy at age 65 in the U.S. versus a few selected European countries. And I wanted to know the level of sensitivity of your cutoff point. And what I was thinking when I saw that number was the women with breast cancer in the U.S. versus Europe who get better treatment, better life expectancy, or patients who require dialysis, who may be in their 40s or 50s, not certainly at that 65 point. But I wanted to know how sensitive that is, because I think with those kind of examples, and added the multicultural demographic mix in this country versus others, may be contributing to some of the differences in that chart.
Oh, absolutely right. It's not going to be sensitive to very specific cases. This is a crude aggregate measure. These countries were picked in part because of their similarities demographically, and I mean, they're not perfectly matched, but wealth, et cetera, to the U.S. There are remaining differences for sure, but I think that it would be very hard to attribute this to cultural differences, et cetera, with the possible exception of the these are not European countries. There's Japan, which is is arguably different. For example, much lower rates of surgery there than in the other countries. But then there's Canada, which has a somewhat different racial composition than the US, but otherwise is very similar in many respects.
I'm Richard Price, AdvaMed. I'd like to take your last question there, keeping Americans healthy longer, and related to the first part of your talk about health system delivery reform contained in the recently enacted legislation, which will result in more federal demonstrations and programs dealing with bundled payments, as you pointed out, ACOs, more innovation in delivery mechanisms in general. So all of those mechanisms have, or delivery system reforms have, as one of their raison d'etres is controlling cost, as you pointed out. And I'd like to ask you if you've done any thinking about how we assure that patients have access to new technologies, innovative delivery treatments, if indeed those new technologies are more expensive and end up costing more in systems where providers have incentives to constrain the use of more expensive technologies?
That's a really important question. And I'll tell you my view. I don't know what's actually going to happen. But this is, first of all, I want to note one thing. The legislation, a lot of the debate was not about using bundled payment to lower costs. It was about improving quality. Now, you may say that was pure rhetoric. I don't think so. I think quality is a huge part of the motivation. And the idea is that you would have good quality measures, and there will be a lot of effort put into good quality measures. So, for example, if you have bundled payment for a condition like diabetes, you're going to look at whether the patients have good control of their blood sugar, of their hypertension, their other cardiac risk factors. So there will be incentives to make sure you do a good job, and that's why if you have a better product, to help them achieve that goal. For example, if you had a way that would get around the problem of non-compliance among diabetics, maybe with a device instead of taking insulin or drugs, that would be a huge hit, and it would be worth a pretty hefty payment if it really worked that way. So there's a lot of motivation for quality. But what if a new technology comes along and it costs a lot more? Will there be incentives to adopt it? And my claim is yes. And this is part of what comparative effectiveness research has to contribute. You have research showing that it's better, and then it will become, the guidelines will presumably say, especially if it's cost effective. Now, the legislation is not very clear about using cost effectiveness, but it clearly doesn't explicitly promote it. But if it's something that really delivers huge impact, it's very likely to be the recommended treatment, and then the payments for the bundles should reflect that. When you look at the current DRG payment under Medicare for hospitals, you could say, what's the incentive to adopt a new technology, at least before it gets a separate payment code under the DRG system? And the answer is presumably, well, when Medicare does its update formula for setting the DRG rates, it reflects the greater usage of this technology. I don't think that's a very good system, but that's the worst case, in my view, for bundled payments. So I actually think if something works well, it's going to thrive almost no matter what we do to the payment system, if it clearly works.